So the focus of our program of research has been on what we've called contextual error. And contextual error refers to a error that occurs in the decision-making process when physicians are planning care for their patients that is, in many respects, excellent care. They followed guidelines, it's algorithmically correct, but fundamentally misses opportunities to provide appropriate care when patients reveal things going on in their life circumstances that are really essential to address.
Imagine a patient whose asthma is getting worse because he's lost his job and can't afford the expensive brand name medication he's been taking, so he's skipping doses. A physician who was paying attention to context ought to be able to identify the problem and prescribe a less expensive generic medication. This kind of a care plan would address the patient's need, and we would call that a contextualized care plan, and we'd call that kind of decision-making patient-centered because it addresses the context that the patient brings in order to make effective clinical care.
We've often found that physicians will miss these clues, and the patient may walk out with a dosage of a medication that's they're already not able to afford, and they've just been told take more of it. So that would be an example of a contextual error.
So when we first started studying contextual errors, the big challenge was that they're hard to identify. You can't just get them out of the medical record.
Of course, what's missed is that the physician missed what the patient told them. So as you can see, these are errors that have very significant effects for patients, but you can't pick them up from the medical record. So our challenge has always been how to identify them.
In a prior study, which appeared in the July 2010 issue of Annals, we worked around this methodological challenge by employing actors as unannounced standardized patients.
In this study, we transitioned to using real patients, and in addition, we've done this surreptitiously in the same way that we did the last study surreptitiously. The physicians, of course, they agreed not to know when they were being audio recorded. So that was the challenge. We had to go from a situation where we were setting the condition using actors to a situation where we had to be able to code whatever happened during a visit. And that required developing essentially a coding mechanism, a coding process, to determine whether in fact there were contextual issues, we call them contextual red flags of course, whether the physician picked up on them, whether if they picked up on them, the patient revealed real factors, issues that the physician could help them with.
Of course, the great benefit of using real patients is that now we know something about the actual frequency and types of contextual errors that occur when real patients are seeking care from their real physicians. When our patients left their physicians with a contextualized plan of care, the contextual red flags that they came with were more likely to resolve, and they had better healthcare outcomes.
The challenge, of course, is what can we do to improve physician performance in this key domain?
You'll see in the references in our current paper that we've been exploring this challenge by trying to develop educational interventions that improve physicians' abilities to contextualize care.
And I think the next step for us is really to start to understand better what we can do to improve physician performance in this area. I think what this study fundamentally has shown is that it's worth the effort, that if physicians are paying attention to these contextual factors and are really providing patient-centered care plans, that the outcomes do in fact seem to be better.